Our erythrocytes live 100 to 120 days, and again, they are a nucleate, so they cannot synthesize new proteins, they cannot divide or grow. Glucose is their main metabolism form of food or for energy, and they can create a little bit of ATP. And our red blood cells, as they're going through their life journey, can get trapped in our smaller circulatory channels, like our spleen, where their macrophages are hanging out and their phagocytosed and broken down. When a red blood cell is broken down, it's broken down into heme, iron, and globin that are separated. The iron will bind to ferritin or hemosiderin where it's stored. Heme is broken down into a yellow pigment called bilirubin, and then globin, the protein backbone, is metabolized into amino acids. Specifically bilirubin, though, the liver will secrete bilirubin via bile into our intestines, and therefore it can be broken down further into urobilinogen, which then is the brown pigment called stercobilin that leaves via our feces and creates that brown color of feces or stool. I mentioned a couple types of anemia before, and it's important to note that anemia is just body has or the blood has low oxygen carrying capacity, and it's too low to support normal healthy metabolism. So symptoms can be fatigue, shortness of breath, dyspnea, chills, palpitations, etc. You can see pallor as a sign, palmar pallor or conjunctival pallor. And there's lots of different categorizations of anemia. This could be oftentimes due to certain underlying issues like blood loss or too many red blood cells being destroyed, or not enough red blood cells being produced. When we look at our blood loss subtypes, we have acute or chronic hemorrhage. In an acute hemorrhage, we'd see a rapid blood loss, and this would be treated with blood replacement. A chronic hemorrhage would be a slight persistent blood loss, maybe a hemorrhoid or an ulceration, and you'd want to treat the underlying cause. For an anemia subtype where there's not enough red blood cells, we can look to iron deficiency anemia as an example. This could be due to a hemorrhagic anemia or low iron intake or even impaired iron absorption. Our cells are smaller, they're microcytes, they're paler, and they can't really synthesize hemoglobin because there's not enough iron. The treatment then is iron repletion or iron supplementation. Another not enough red blood cell is pernicious anemia or a megaloblastic anemia. One example of this is in our pernicious anemia, we can see the destruction of our stomach mucosa that produces intrinsic factor from our parietal cells. We need intrinsic factor to absorb B12, and specifically, intrinsic factor binds to B12, prevents it from being broken down, and then allows it to bind to our receptors in the ileum and move inward into a cell via pinocytosis. B12 is required for our red blood cells to divide. There's autoimmune etiology. That's what pernicious anemia is. You also could see it, though, acquired from a vegan or vegetarian diet if there's a low intake of vitamin B12. The red blood cells are not small in this condition. They're large. They cannot divide, but they still get bigger. And the treatment is B12 injections and or supplementation, and B12 can be stored in the liver. You can also have, and similarly, a folic acid deficiency. And folic acid's in leafy greens or green veggies, fruits, and meats. It can get destroyed during cooking, and that can lead to a dietary deficiency depending on food intake types and food preparation methods. And therefore, we need to look at our intestinal malabsorption because we could even potentially have a concomitant B12 and folate deficiency. There are renal anemias where we can have a lack of EPO. The kidneys can't produce it for whatever reason. We often see this with concomitant renal disease, and the treatment would be giving synthetic EPO. We also can have an aplastic anemia. This is destruction or inhibition of bone marrow, red bone marrow, lots of different causes. All of our formed element cells are affected. So this is not just anemia. You'll see issues with clotting, immune deficits, and short-term transfusions and long-term transplanted stem cells would be the treatment. Now, in too many red blood cells destroyed, you could see a hemolytic anemia. This is where we have a premature lysis or breakdown of red blood cells prior to its typical timely death at 120 days-ish. Lots of different etiologies, specifically to note some hemoglobin abnormalities that can be genetic. This includes our thalassemias and our sickle cell anemias. Thalassemia does have a Mediterranean ancestry. There is a genetic link. And typically in thalassemia, you'll see just one globin chain is either absent or faulty. The red blood cells then are more thin, they're more delicate, and they're more deficient in hemoglobin. And there's so many subtypes. The prognosis will depend on the subtype specifically. In sickle cell anemia, we have hemoglobin S instead of hemoglobin A. And this is a mutated form of hemoglobin where one amino acid is wrong in a globin chain of 146 amino acids. We can see here that we have normal erythrocyte has a normal hemoglobin amino acid sequence in the beta change, and then we have a sickled hemoglobin, and that's from a single amino acid change in the beta change to a valine. Histologically, they become these crescent-shaped cells when our oxygen levels are low, such as during exercise. And the crescent shape will increase the risk of rupture as well as the blockage of our small blood vessels. There is a genetic link. There is an increased prevalence in locations where malaria is prevalent. And this is because sickle cell anemia actually is protective against malaria, because persons with sickle cells have a decreased likelihood of contracting it. Malaria does kill around 1 million persons each year. And one hemoglobin S, a sickled hemoglobin, and one normal or a hemoglobin A will lead to a milder sickle cell disease and improved survival from malaria. But two copies of hemoglobin S will lead to more of a severe sickling disease. But there'll be almost a fully reduced, if not completely absent, instance of contacting malaria. Essentially, the cells die off too fast for malaria to complete its life cycle. Transfusions, nitric oxide are things that can treat an acute sickle cell crisis. And really, you're looking at preventing things from the most part. Polycythemia is a different pathology. It's essentially excessive red blood cells, and we see this with increased blood. There's increased blood viscosity or thickness, and blood flow can be sluggish. Polycythemia vera or secondary polycythemia are more common, although athletes can blood dope this, and they can remove their blood, store and reinfuse it prior to an event to increase oxygen for stamina. Looking at polycythemia vera, this is a clonal abnormality. It leads to excessive proliferation. It is essentially a bone marrow cancer that affects all lineages. You'll see an elevation in red blood cells, an elevation in hematocrit, an elevation in blood volume, and hyperviscous blood, very thick blood. And you treat this with bleeding or essentially phlebotomy, therapeutic phlebotomy versus secondary polycythemia. Secondary polycythemia is caused by low oxygen levels or higher altitudes, chronic hypoxemia or heart and lung disease. We oftentimes see this also could be caused by increased EPO production. Our red blood cells increase by about 30%, and there's about 6 to 7 million. When we come back, we're going to look at platelets as another factor here of our hematologic system.